Good morning, good afternoon, everyone. Really excited for everyone that's joined today, and I hope we will see more. We have a lot of folks that registered for this important discussion. I'm Dr. Elizabeth Garner. I'm currently the president of the American Medical Women's Association, and welcome really to today's AMWA's congressional briefing. The title of this really important briefing is The Heart of It All: Impact of Obesity on Cardiometabolic Health. We have a huge and major growing epidemic in this country, and that is obesity. And today we're going to hear from some amazing experts in this space in obesity medicine, really in the hopes that together we can work to improve the care of patients. So first, I want to thank our co-sponsors. We've got several. So the Alliance for Women's Health and Prevention, Healthy Women, the National Association of Nurse Practitioners in Women's Health, Obesity Action Coalition, Obesity Medicine Association, Society for Women's Health Research, and the Obesity Society. And so thank you so much for all of your support. And then I'd also like to thank Novo Nordisk for their support of this briefing. So AMWA is just super proud of the fact that we celebrated our 108th anniversary just last month. And so for really over a century now, AMWA has been really working hard to tackle unmet needs in healthcare, and this is certainly one of them. I'd like to thank our lead co-sponsors, Congressman Dr. Brad Wenstrup, Dr. Raul Ruiz, Dr. Bill Cassidy, Tom Carper, and Congressman Dr. Marionette Miller-Meeks and Gwen Moore, the Treat and Reduce Obesity Act was introduced previously in Congress and again in the 118th Congress, both in the House and the Senate. And this important bill would help establish obesity as a chronic disease, which I certainly believe that it is, and would also address gaps in accessing obesity treatment, which is a major problem for many around the country. So again, as I mentioned today, you're going to hear from experts in obesity care. You're going to hear from a patient with a remarkable story. And then we'll close with a summary of this bill in hopes that we can increase bill co-sponsors and move this legislation forward. Briefly, I'd like to introduce the members of Congress, and we're going to get some opening remarks here. We're so honored to have members of Congress, including the doctors in Congress, leading the effort to educate their colleagues and raise awareness about the chronic disease of obesity and to address gaps in accessing healthcare. We'll now hear some remarks from Congressman Marionette Miller-Meeks of Iowa. Dr. Miller-Meeks served for 24 years in the United States Army as a private nurse and doctor before entering private practice in 1997. She also served as the director of the Iowa Department of Public Health.
Hello, everyone. Thank you for inviting me to join you to discuss why we must treat obesity like other chronic diseases and promote effective treatments for obesity. H.R. 4818, the Treat and Reduce Obesity Act, TROA, provides a direct line to chronic weight management medications for Medicare recipients struggling with obesity. As a physician, I believe we must support and utilize medical breakthroughs that are proven to help patients and reduce costs to the healthcare system. This legislation helps combat the obesity epidemic by increasing access to groundbreaking medical treatments and screenings that are currently not covered under Medicare. I introduced the Treat and Reduce Obesity Act, TROA, with Dr. Brad Wenstrup from Ohio, Dr. Paul Ruiz from California, Gwen Moore from Wisconsin, and Senators Bill Cassidy from Louisiana and Tom Carper from Delaware. According to the Centers for Disease Control and Prevention, obesity is prevalent in over 40% of adults aged 60 and older. The National Institute of Health attributes obesity to an increase in risk for many health problems such as type 2 diabetes, high blood pressure, heart disease, stroke, fatty liver disease, and certain cancers. This bill would expand which healthcare providers can bill Medicare for intensive behavioral therapy related to obesity to include clinical psychologists, registered dietitians, or nutrition professionals if the patient is referred to these new healthcare providers by a physician. This legislation would also allow medications that are FDA approved to treat obesity to be covered under Medicare Part D. The Treat and Reduce Obesity Act is endorsed by the American Diabetes Association, the American Gastroenterological Association, the American Academy of PAs, the Association of Diabetes Care and Education Specialists, the American College of Occupational and Environmental Medicine, the Academy of Nutrition and Dietetics, the American Psychological Association, the American Society for Metabolic and Bariatric Surgery, the Obesity Coalition, the Obesity Medicine Association, the Obesity Society, Weight Watchers, the Stop Obesity Alliance, the Diabetes Patient Advocacy Coalition, the Diabetes Leadership Council, the National Kidney Foundation, National Consumers League, and the Endocrine Society.
Thank you so much, Congresswoman, for those remarks and the incredible leadership on this important issue. So I'd now like to introduce my colleague, Dr. Eliza Chin, who's the Executive Director of AMWA.
Thank you so much, Dr. Gardner. Before we introduce our first speaker, I want to note that our chat is open for all to share their thoughts and comments. Please feel free also to share where you are from in the chat. We will also have time for Q&A at the end of the briefing, so please drop those questions into the chat as well. Finally, we will send the recording and summary information to all who registered for today's briefing. As Dr. Gardner mentioned, AMWA has worked over a century to help address unmet needs in medicine. In our work to address women's health, we became concerned about the growing epidemic of obesity. During the past 2 decades, U.S. obesity prevalence has increased from 30.5% to 41.9%. And while the rates of obesity are similar overall between men and women, when broken down by race and ethnicity, non-Hispanic Black women had the highest age-adjusted prevalence of obesity of any group at 57.9%. So last year, we convened a multidisciplinary stakeholder roundtable to discuss women and the obesity epidemic. Key points from the roundtable included the need for more research and education, including a focus on sex and gender differences, the need to destigmatize obesity through empathy and patient-centered language, the importance of coverage for obesity treatment, and limitations of body mass index as a measure of obesity. We'll be sharing a copy of the roundtable proceedings as well with everyone who registered. Next, we are honored to have our first speaker, Dr. Fatima Cody-Stanford, join us to give a background on obesity, its contributors, and how the stigma surrounding it is a barrier for addressing this chronic disease, unlike any other. Dr. Stanford is an associate professor of medicine and pediatrics who practices and teaches at Massachusetts General Hospital and Harvard Medical School. We're so honored to have Dr. Stanford with us today. Thank you so much for your time. I'll hand the microphone over to you.
Thank you so much, Dr. Chen. It's a delight to be here. As we look at the prevalence of obesity, and Dr. Chen really gave us a great entry into addressing this major chronic illness, the most prevalent chronic illness in human history here in the United States and around the world, and that is this of obesity. She talked about the disparities, the racial and ethnic disparities as we look at obesity here in the United States and the disproportionate impact on Black women, persons that look like me here in the United States. But let's look at this prevalence of obesity here in the United States as we look at all individuals here in the United States. And this is based on the behavioral risk factor surveillance system here in 2022. We're going to be looking at the next few slides, which are going to be heat maps. And when we're looking at heat maps, you can imagine that the darker, the more intense the color that we're looking at, the more prevalent the disease. And so in this particular first map that we're looking at, I do want to point out that we're going to be looking at what we're looking specifically at the prevalence of obesity in these areas. I do want you to note that when we're looking at less than 20% prevalence of obesity, if you look at this map of the US and wherever you might be located, that if we look at this slide, we can't find a state or territory of the United States where there's less than 20% prevalence of obesity. If we look at our nation's capital of DC, we do see between 20 to 25% prevalence. And please note that we're looking at self-reported weight and height. The reason why it's important to note that this is self-reported is that you can imagine that we tend to underreport our weight, meaning we tend to be very nice to ourselves and give weights that are a little bit nicer than what the actual scale actually tells us. When we get into that yellow color, we're looking at a prevalence of 25 to 30% prevalence of obesity. So if we're looking at where I'm located, for example, in Massachusetts, Colorado, California, Hawaii, Vermont, New Jersey, for example, you're looking at between 25 to 30% prevalence of obesity by self-report data. When we start getting into orange, we're looking at 30 to 35%. A little bit of that kind of darker, more tangerine color between 35 and 40%, darker between 40 to 45%. And when we start getting to that really dark color, we're looking at 40 to 45% prevalence of obesity. Let's go to our next slide, please. And I want us to start breaking this down, looking at this by racial and ethnic group here in the United States. We're going to first start off by looking at non-Hispanic white adults and looking at what we see between the racial ethnic groups here in the United States. And we will look at all of the major groups in these next several slides. So if you're looking here, I do want to point out that if we're looking at, for example, Hawaii and DC, you'll notice that we have less than 20% prevalence of obesity, and we do have Guam, for example, in Colorado with those lesser numbers. We see kind of that kind of orangey color kind of located in the South and Midwest areas, if you note there. And I do want to point out West Virginia, for example, with kind of that higher prevalence amongst non-Hispanic white adults. If we go to my next slide, I do want to point out that we're getting into looking at non-Hispanic Black adults. And Dr. Chen already pointed out that we do have higher prevalence in non-Hispanic Black adults. And this is what particularly drew me into the field. I was born and raised in the American South in my home state of Georgia, particularly in Atlanta, Georgia. And this particularly drew me in. I want to point out specifically here that we're looking at a lot of this really deep color, looking at prevalence of 45 to 50%, particularly in a lot of the southern states of Alabama, Mississippi, Louisiana, Arkansas, Oklahoma, North Carolina, Virginia, Tennessee, and Wisconsin, for example. Here in this particular map, looking at the prevalence, high prevalence of overweight and obesity amongst non-Hispanic Black adults in this particular map. If we go to our next slide, please. I want us to look at Hispanic adults. And I also want us to pay attention to the distribution and prevalence of where we're located. For example, where individuals of different racial ethnic groups may have a higher concentration. So here you're going to notice a different distribution of overweight and obesity, noticing key states where you may have a higher distribution of Hispanic adults. For example, in Texas, here you'll see also Mississippi, Kansas, higher prevalence of overweight and obesity in these areas where we see those darker, more higher representation of overweight and obesity in those areas. I want us to go to our next slide. And in this particular slide, we're going to pull out non-Hispanic Asian adults. Now, I was a bit disappointed here in the CDC when they gave us this map, because we do know that when we're looking at Asian adults, and they did group all subgroups of Asian adults here, it makes it seem as though we're not dealing with an issue of obesity within Asian adults, but we do know that the cutoffs for Asian adults, particularly as we're looking at issues such as BMI or body mass index, actually are significantly lower for Asian adults compared to other individuals. And what do I mean by that? We mean there's a higher risk of metabolic disease at much lower BMI cutoffs. And so this map is not technically drawn to scale to accommodate that. We know that at a BMI of 25, we're dealing with issues of obesity, higher risk of issues like non-alcoholic fatty liver disease, and insulin resistance in Asian adults. And so this map is not quite drawn to represent that. So it gives a false representation of security in this particular map, looking at non-Hispanic Asian adults. Now, this next map, next slide, is the first time that we've actually seen a map of non-Hispanic American Indian and Alaska Native adults. And so I applaud the CDC for actually giving us for the first time a map that represents our Native Americans. And I want to show this map because we also see, again, that distribution when we're looking at our reservations and seeing that high prevalence amongst these groups. Look at areas that we haven't typically seen represented in the maps: North Dakota, Minnesota, Oklahoma, New Mexico, Arizona, Nevada, Utah, and Idaho, for example. High representations of obesity within those areas, really, really high, but really noting where these populations tend to be represented. And I just wanted to demonstrate this high degree of obesity within this population. Like I said, the first time we've seen this map in this population. Now let's go to our next slide because I really want to get into this idea of energy balance. And we have learned for so long that energy balance is indeed very simple. It's just a matter of calories in, which is our food and beverage intake, and calories out, a matter of just bodily functions and physical activity. And if we can just get this correct, right, just eat less and exercise more, then we should all be exactly the size we want to be. But if we go to our next slide, we'll recognize that it is really not as simple as this very simple equation, because all I would have to do to each of us listening is just give you a calculator, and you should just be able to calculate your deficit, and then we'd all be exactly the size we want to be. And if it were that simple, we would need to not have this conversation today. So let's go to our next slide, and we need to recognize that obesity is indeed a multifactorial disorder where genetics, environment, development, and behavior all play a role in a person's likelihood of having this chronic disease. And if we go to our next slide, we recognize that this is a matter of a brain disorder, and our regulation of food intake is a matter of a communication with the brain, with the gut. So the brain, if we were to go to this side of the B side here, the hypothalamus is getting signals from different parts of the body. It's getting signals from our adipose, and adipose is just a fancy word for fat. It's communicating with our large intestine, our small intestine, our pancreas, and our stomach to tell us not only how much to eat, but also how much adipose or fat to store. And so if we go to our next slide, I want us to focus on this key diagram. And don't worry, I'm not going to take you to science class, but I do want us to recognize that there's two primary pathways in the brain that do regulate our weight. And we're going to focus on this bottom pathway first, and promise you after we do this, we'll get back to more normal things to really focus on this issue. So leptin is a hormone that signals from adipose or fat cells. And when it binds to this receptor on the bottom, it stimulates a neuron in the brain called our POMC, or our pro-opiomelanocortin neuron. And when that signal or cascade of event goes off, it stimulates our anorexigenic signal. When you hear anorexia, you hear a decrease in food intake, and it stimulates something in our brain called the BDNF. BDNF stands for brain-derived neurotrophic factor. And when you have high levels of BDNF, you have a lean appearance. So when you look at someone with high levels of BDNF, they appear lean. And so we judge someone and we assume that they must just eat a little amount. And we assume that they are just virtuously doing something very, very great. They just must eat less and exercise more. But a lot of it just has to do with how their brain signals, okay? As I exclusively care for patients with overweight and obesity, often they don't signal so well down that pathway we just talked about. Indeed, they signal down a different pathway of the brain, where leptin binds to a different neuron and it signals a different receptor and signals a different neuron in the brain called the AGRP neuron. And when that cascade of events happens, it inhibits or blocks the formation of BDNF. It sends off an orexigenic signal. Now, orexigenic is the opposite of anorexigenic. It increases one food intakes and drops the formation of BDNF. That person appears to carry more adipose. We judge them based upon that adipose. We assume they just don't eat well, they don't exercise enough. We have these stigma and bias associated with how they look, and we judge them based upon that, when a lot of it, like I just said, is in the brain and how the brain is regulating their weight. Now I want to go to the next slide because I may have lost some of you there, because I want to talk about what actually contributes to this obesity epidemic that we're seeing here in the US and around the world. And I want to take you to this slide from the Obesity Society from 2015. And I want to talk about what's contributed to this obesity epidemic. And I want to tell you that there's factors on the left side of the screen that are inside of the person that contribute to us having obesity. And I want to show you that there's factors on the right side, outside of a person, that have contributed to someone having obesity. Now, in this top row, I want you to see that those are factors that increase one's intake. These are things that make you eat more, basically, okay? And at the bottom, there are things that decrease how much you're able to burn. So you burn less. And in the middle, these things affect how much you eat, or how much you burn, or if you really focus in really close to the screen, you'll see there's a little word that says unknown, meaning we're figuring things out. Now you may be like, Dr. Stanford has all these colors going on. What does that mean? These colors are contributors or influencers to our weight. So things that are in dark purple are environmental pressures on physical activity. Things like our built environment. And things in lavender are biological or medical reasons why we may struggle with weight. Things like age-related changes, which are extremely pertinent, for example, in women's lives. There are 3 major times in women's lives where we may see major weight shifts. When we first get our menstrual cycles as adolescents, at pregnancy, whether or not that leads to a viable offspring, and at the also desired menopause. And I say that a little bit facetiously, where we go from having a gynoid distribution of weight where we carry in the hip, buttock, and thigh region, to having an android. For those of you who happen to have an Android phone, I feel sorry for you, but android means male-like distribution of weight we carry in our midsection. Or genetic and epigenetic factors, or weight-promoting medications, for example. What about the gut microbiota? The gut microbiota, or bacteria in the gut of individuals that are lean, differ from those that have obesity. These are biological or medical reasons why some may struggle with weight. Now in yellow, these are maternal or developmental reasons why someone struggles with weight. What about things in pink and orange? These are the only things we ever hear about why people may struggle with weight. Economic reasons, people from low socioeconomic position, people that struggle with resources, food and beverage behavior and environment. We hear a lot about these things. People that have poor energy density with regards to food, lack of family meals. These are things that we know contribute to obesity, but these are really the only things we ever hear about. What about psychological reasons people may struggle with weight? Disordered eating, binge eating disorder, which is actually the #1 eating disorder here in the United States. What about weight cycling, going on this diet, and then this diet, and this diet? We hear about a lot of these things, particularly as we're approaching the new year. What about social reasons why someone may struggle with weight? Mood disturbances, things of this sort. Also, let's go to our next slide. I want to talk about bias. I talked a little bit about this. Dr. Kahan, that you'll hear from later, this is one of his key areas of interest. But I want to talk about the 2 most common forms of bias in Western society. And the 2 most common forms of bias are race bias followed by weight bias. So let's talk about race bias. Race bias is you look at me as a Black woman and you make assumptions about my value worth based upon my Blackness. And I know you probably did when you saw me. And I accept that, and I know that to be true. And indeed, if you did a Google search for young Black teens in 2016, you were met with a search algorithm that returned only mugshots of young Black boys. If you did the exact same search for young white teens in 2016, you were returned with smiling faces, as you see on this slide. When this story ran in the Washington Post on June 10th, 2016, you can imagine that Google changed their search algorithm. In the same way that there's bias with regards to weight, we have bias with regards to people that carry excess adipose. This story that ran in Glamour magazine on May 2nd, 2012, demonstrates bias that we have to people that carry excess weight. So when we have individuals that are leaner, we see them as superficial or ambitious or conceited or confident or mean. In a similar way, if someone carries excess adipose or excess fat, we see them as lazy, giving, insecure, undisciplined, carrotless, passive, or nice. And we have these biases. So imagine if you happen to be a person that is Black like myself and you carry excess adipose. Imagine how those dual identities contribute to an intensified bias in our society. Next slide, please. I want to talk about toddlers' bias and maternal anti-fat prejudice. In this particular study that came out in 2016, they looked at mothers and children, and they found that older infants, meaning infants that were about 11 months of age, actually had a bias of looking at figures that carried more weight. But by the time they were 32 months of age, they instead preferred looking at leaner figures. And this was based on maternal anti-fat attitudes. Now, when I presented this to parents before in person, mothers will come up to me and say, well, I don't say anything negative about people that carry excess weight, but it's also what you're not saying. Let's say you're watching television or some type of social media ad with your child, and you always comment positively about those with leaner figures and never say anything positive about those with more excess weight. You have stated, without stating it, that you only identify something positive with someone that carries a leaner figure. Next slide, please. And so let's talk about this idea of weight stigma. This is one of my favorite diagrams to talk about weight stigma and how it affects those that carry excess weight. So when a person experiences weight stigma, it affects and leads to stress. That affects their eating and physical activity behaviors. We see binge eating, increased caloric consumption, maladaptive weight control, disordered eating, lower motivation for exercise, and less physical activity. That actually leads to physiologic changes where we see increased level of stress hormones like cortisol or C-reactive protein, higher hemoglobin A1C, which is a higher blood sugar, and elevated blood pressure. That affects healthcare services where we see poor treatment adherence, less trust of us as healthcare providers, avoidance of follow-up care, a delay in preventive health screenings, and poor communication. All of this subsequently leads to weight gain, which affects psychological health and distress. We see depression, anxiety, low self-esteem, poor body image, substance abuse, and even suicidality. This in turn affects physiologic health and distress, where we see poor glycemic control, less effective chronic disease self-management, more advanced and poorly controlled chronic disease, and unfortunately, lower health-related quality of life. Next slide, please. So what have we done? At the American Medical Association level in 2017, I worked with the AMA to help pass language to at least address the language that we're using when we're talking with patients with obesity. And this is the language that we passed. Our AMA encourages the use of person-first language, patients with obesity, patients affected by obesity in all discussions, resolutions, and reports regarding obesity. We encourage the use of preferred terms in discussions, resolutions, or reports regarding patients affected by obesity, which include using weight and unhealthy weight, and discouraging the use of stigmatizing terms, including the words obese, morbidly obese, and fat, and educating healthcare providers on the importance of person-first language for treating patients with obesity, equipping their healthcare facilities with proper size furniture, medical equipment, and gowns for patients with obesity, and having patients weigh respectfully. And then subsequently, next slide, go back. Just on October the 17th, working with the World Obesity Federation, I helped write this position statement on recognizing and reducing weight stigma, where we distinguish between body size and obesity, promote human rights-based approach to tackling weight stigma and discrimination, increasing the global evidence base, considering individual language preferences, using non-stigmatizing language and imagery, using person-first language, engaging in weight-neutral health promotion, raising awareness of weight stigma, and engaging in legislative and policy efforts to reduce weight stigma, just like we're doing here today in this AMWA briefing. Next slide. I do want to thank you so much for your time. Again, I'm Dr. Fatima Cody Stanford, an obesity medicine physician scientist at Mass General and associate professor of medicine and pediatric at Harvard Medical School. Feel free to follow me on LinkedIn, Instagram, and X, or whatever it is called today or tomorrow. At Ask Dr. Fatima. Thank you so much for your time.
Thank you so much, Dr. Stanford. I learn more every time I listen to you speak. If anyone has questions for Dr. Stanford, please feel free to put them in the chat. We will address as many as possible at the end of the briefing. And next, moving along, I'd like to introduce our next speaker, a very special speaker, Alicia Smith, who will share her personal story. Alicia is a nurse from Lakewood, Ohio, near Cleveland, and we are so grateful for you, for your generosity in speaking today.
Hi, thank you for having me. Hopefully you can hear me okay. My name is Alicia Smith, and I'm from Lakewood, Ohio, just outside of Cleveland. I am 37 years old, and I'm here to share with you my experience battling obesity, which I called my search for Wonderland in my journal, as I documented my struggle to get myself under 200 pounds and into the 100-something pound zone this past year. I've been a person with obesity for about 16 years, with my BMI being above 40 for the last decade. My highest weight I reached in May of 2022, 265 pounds, a BMI of 48.5. I also had been pre-diabetic since 2014, with my most recent hemoglobin A1C being 6.1, a level very close to a diabetes diagnosis, and that number really scared me. As a nurse myself, I know what havoc diabetes can do to the body. What finally motivated me to change, my official aha moment, happened on a trip to Hawaii in summer of 2022. Our family was in Maui, headed out to do a hike, and I was out of breath just walking to the entrance from the parking lot. I looked up at the massive mountain and knew in my heart I could not physically do it. I regretfully chose to sit at the bottom and watch my family hike instead. I sat for about an hour as people of all ages passed me by, and I was feeling every kind of emotion in that moment, including sad and angry. But I did not let go of the feeling of wanting to get myself into a better state of health. After only losing about 6 pounds in a year and a half during the pandemic, I was using my new treadmill weights and dieting. I decided to ask my primary care provider for a referral to bariatric medicine. It took about 4 months to get an appointment, but in September 2022, I met with my bariatric doctor, who decided I would be a good candidate for the injectable medication Mounjaro. I signed up online for the manufacturer coupon savings card, which allowed me to fill the monthly prescription for $25, and I was able to get it filled that day at my employer pharmacy. I did not fully understand at the time, but medications to treat obesity were not covered under my insurance plan. It wasn't until I went in for my normal refill in July of 2023 where I was told that the coupon had officially changed to $500 and $550 per month. That's when I realized I was paying completely out of pocket on my own for this medication. I panicked because I did not feel prepared. I ended up pulling some money out of my savings and buying that $500 50 box, but I knew I would not be able to afford another box. I looked into alternative ways I could go about getting it, but everywhere I looked without that coupon, it was about $1,400 a month. My doctor said he was hearing the same stories from many other patients, and he himself was overwhelmed by the experience and at a loss on how to help. For my results, in the approximate 1 year of being on Mounjaro, I was able to lose 100 pounds. All of the hard work I was doing with my diet and exercise finally seemed to be paying off, and it felt really good. I got down to 165 pounds, which brought my BMI to 30.2, which is right at the obesity cutoff. I am now no longer pre-diabetic. My hemoglobin A1C is 5.1. I no longer have plantar fasciitis. I no longer have chronic back pain. No more acid reflux. I sleep better. Everything about my life is better. I recently completed a 5K equivalent run with my husband. That included a really big hill. I was really proud of that. My last shot of Mounjaro was September 28th of this past year. Since then, I've gained about 5 pounds despite sticking to my calorie and exercise goal. I'm trying to remain positive, but I am worried. My biggest hurdle in all of this, however, this past year wasn't the actual weight loss itself, which surprised me. It was dealing with the anger I felt not being able to afford a treatment my doctor and I chose, which had been working exceptionally well for me this past year, and suddenly no longer was an option because of cost. This anger was exacerbated by having to enter a hospital every day and care for patients as a nurse, while myself not feeling cared about as a patient and recipient of healthcare with a valid disease. So my final thoughts for you are I'm hopefully here to inspire you to see that people with obesity are capable of recovery and that they are capable of thriving in their new healthy lifestyle. There are people out there like me who are stuck in this obesity mud pit. There are people who could really use the help of comprehensive treatment options like therapy, medication, and surgery to help them achieve their goals before they may give up for good. Everyone with obesity deserves safe and effective treatment options, in the same way that treatments are covered for other diseases like hypertension. My story and the hurdles described above are the story of a decently privileged young white female who has a good paying nursing job at a well-known healthcare institution with good healthcare coverage. Imagine how much harder obesity care and treatment is right now for others across our healthcare system who do not have the resources that I do. I encourage you to support the Treat and Reduce Obesity Act. I know that the government supporting this positive change in Medicare will encourage private insurers to mirror their policy, and that ultimately could one day help people like me too. I believe obesity is something both political parties can agree will continue to be a growing concern to public health. To not act now would truly be a missed opportunity. And lastly, the issue of obesity, it is your voters, your family, your friends, it's your healthcare system. I know you personally care about and love people struggling with this disease. Let's get them comprehensive options to be available and to be affordable to treat it. And that's my story.
Thank you so much, Alicia, for sharing such a powerful personal story and helping us all to understand the patient perspective. The voice of the patient is central to the work that we do in addressing obesity. I would now like to introduce our panel of obesity medicine specialists. Dr. Scott Kahan will serve as our moderator today. Dr. Kahan is the director of the National Center for Weight and Wellness and serves on the faculties of the Johns Hopkins Bloomberg School of Public Health, the George Washington University School of Medicine, and the George Washington University School of Public Health and Health Services. Dr. Angela Fitch is the president of the Obesity Medicine Association, founder and chief medical officer at Known Well, and former co-director of the Massachusetts General Hospital Weight Center and faculty at Harvard Medical School. Dr. Tiffany Bell Washington is a medical director on health policy and health equity research and faculty at Massachusetts General Hospital in the Pediatric Psychiatry Department and in her private practice, The Healthy Way, which focuses on prioritizing stress management, lifestyle medicine, mental health, and obesity treatment. I'm going to hand the microphone over now to Dr. Kahan.
Thanks everyone for being here at this briefing. At the core of what we're doing here is trying to address this issue because it causes so much health problems and ultimately healthcare costs. Obesity increases the risk for countless diseases. If you could click on the slide, please. And essential part of the reason why is that fat cells make hormones and other chemicals that essentially act as toxins in the body. And so by doing this, it can increase the risk of diseases across every single organ system of the body. If you could click on the slide again, please. So here you can see obesity increases the risk of lung diseases, of a range of liver diseases, gynecologic abnormalities. A couple of dozen cancers are increased by obesity. And in particular, obesity increases the risk of what we call cardiometabolic diseases. So if you can click the slide, please. There's a range of health conditions that make up cardiometabolic health. And those includes diabetes, high blood pressure, many kidney diseases, heart diseases, liver diseases, and stroke and other cerebrovascular diseases. These are among the most common diseases in America and Western countries, and they're among the most costly diseases in America and Western countries. And obesity affects all of them. If you can click the next slide again. What's important here, we've been talking a lot about the impacts of obesity on health as well as healthcare costs. But what we've learned over a number of decades of obesity treatment, and especially more recently with the development of newer treatments for obesity, is that we can make a big impact on both obesity and the health risks of obesity. So for example, we know that intensive counseling for behavior change and weight loss and the behavioral change that comes from that counseling can lead to a really significant improvement in the risk of developing diabetes, 50 or 60% reduction in developing diabetes, in fact. Unfortunately, many people don't have access to good counseling for weight loss and obesity. And even for those who do, it's not going to help everyone. Many people try to lose weight, try to make behavioral changes. They have some degree of success, but it may not be enough to prevent the diabetes. If you can click on the slide, please, it'll show here that when we further treat with an obesity medication plus guidance in behavioral change, we can get even better reductions in developing diabetes, as much as 70 or 80% reduced development of diabetes. So that's particularly important, not for the least of which is that diabetes is one of the most costly diseases among Americans. Now, in addition to that, heart disease, of course, is a big issue for many Americans, both in terms of health and in terms of costs. And we know that we can also make a dent on that. So if you can click the slide again, we've known for years that good counseling for behavior change and patients making those behavioral changes and losing weight can decrease the risk of dying from heart disease. The problem is, while that's a great thing to do, only about a quarter of people in the clinical trials of behavioral change and weight loss will lose enough weight to improve their risk of dying from heart disease. So one of the benefits then of using medications additionally is that we can increase the number of people that can make sufficient behavioral changes and weight loss improvements in order to decrease the risk of having heart attacks and potentially dying from heart disease. If you can click on that slide again, I show you that here. That was the point of a really important recent study published that you may have heard of, the SELECT trial, which showed that treatment with medication can reduce the risk of having a heart attack by 20%, potentially more. And next slide, please. So we're going to move on to questions here, but I wanted to make sure that we really focused on not only the risks of obesity, but the fact that obesity is very much potentially treatable, and the consequences of obesity are potentially very treatable. So I'm excited to now be able to talk with Dr. Fitch and Dr. Washington. And so Dr. Fitch, let's start with you here. People are often confused when they hear about obesity being called a disease or a chronic disease. Can you tell us a bit more about why it's important to acknowledge that obesity is a chronic disease and ultimately that it requires treatment like other diseases?
Thank you so much, Scott. And again, I apologize if it's a little bit loud here. I'm actually in DC to testify tomorrow at a roundtable hosted by the Millikan Institute on how employers can help to treat obesity better within our workforce. So again, it is, as Dr. Fatima Cody-Stanford showed us, right, and as you mentioned, obesity is a chronic disease. It's something that has multiple factors, right? A lot of our diseases, such as hypertension, diabetes, cholesterol, have lifestyle components to them. We still work on our lifestyle, but we don't always treat them predominantly with lifestyle alone, because science has evolved to develop medications that allow for even better outcomes with that treatment. And patients all the time come in and say to me a lot of times, you know, I don't want surgery or I don't want to take medication. And nobody wants that. None of us here want to have surgery today, and none of us here want to take a medication if it's our choice. But at the same time, if those treatments help us to live a longer, healthier, more productive life over time, then we typically employ those treatments in order to be more successful, you know, in order to have lives. And as Alicia just gave us a wonderful, overview of her journey. And Alicia, thank you so much for sharing that. We recognize how challenging that can be to share that. And again, you know, you can see how it's a chronic thing that we deal with, and we have to have access to these treatments, just like we have access to other treatments for chronic diseases.
Thank you, Dr. Fitch. So much of today's webinar is focused especially on the effects of obesity on cardiovascular and metabolic diseases. That's, of course, extremely important. But as I showed you in the slide earlier, obesity affects much more than just the heart or much more than just diabetes risk. And so, Dr. Washington, as a psychiatrist, can you tell us about the connection between mental health and obesity, and why obesity treatment is so important to other fields in addition to cardiovascular diseases?
Yes, thank you very much for having me and for the question. So as a psychiatrist, I'm also board certified in obesity and lifestyle medicine, and I often get patients and other physicians who are wondering why those fields go together. So what I would say is that mental health is greatly impacted by your weight, and your weight is obviously impacted by your mental health. And there is a bi-directional relationship, meaning if you have depression, you're at higher risk of having obesity or weight gain. If you have obesity or weight gain, you may or may not have depression. When I see patients and they come in, we prescribe lots of medications to help people with their depression, anxiety, bipolar, mood disorders. And unfortunately, a lot of the medications we prescribe can cause weight gain. And what most people say at that point, because they haven't received training, is, well, you should eat better, you should lose weight, just move a little more. But as Dr. Fatima Cody-Sanford mentioned, that isn't enough. Your patient you may very well be eating well, eating healthy, exercising as much as you can, as active as you can be, and your weight still can climb if you're on certain weight promoting medications. So as a psychiatrist, I make sure to look at that part of it, and then to hopefully de-prescribe some medications that can cause weight gain. But then I have patients who gain 30, 40 pounds on a medicine in a short period of time. And they don't have the proper insurance or ability to even get these medications that we know can reduce their weight and help them return to a baseline that is more appropriate for them.
Thank you, Dr. Washington. I want to go to another question here, both one that came up in preparation for this webinar and also that came up several times in the comments that were put by attendees. So there's a lot of confusion about how obesity is diagnosed and defined, particularly regarding the relevance of body mass index or BMI. Dr. Fitch, can you speak to that?
Yeah, so we know that BMI isn't perfect, but it is fairly easy for us to use, right? Because it is just a calculation of height and weight. So as far as maybe other areas of the world that don't have access to other more high-tech equipment like we have in our office, for example, or even places in the country that don't have access to body composition testing, right? Because as we said earlier, as Dr. Fatima Sanford said too, this is a disease of the adipose tissue, right? And as you mentioned, Scott, this is, an adiposopathy. It's a dysfunction of our adipose tissue or fat cells. So we're really talking about extra adipose tissue, which is BMI is a surrogate marker for extra adipose tissue. And we have some of that data. It is not racial or ethnically diverse. The data is mostly on Caucasian people. So there has been some research being done, looking at different ethnicities and how BMI correlates with mortality or having other disease states. But we do know today that for the most part, BMI does correlate with mortality and with other diseases. So especially as your BMI gets up above 35 in particular, it's pretty decent at saying that there's going to be some sort of health issue with that eventually at some point in time. So again, we have to use it responsibly. And the biggest thing I'd like the world to understand too, when I talk to patients, is that it was never designed as a tool for someone to get to. So in other words, it was designed as a one-time epidemiological point. So if your BMI is this, it increases your risk of X, Y, Z, right? It increases your risk of other diseases, and it increases your risk of death, of dying sooner, right? We have data to show that people with higher BMIs, BMI greater than 40 in particular, have an increased risk of death by 8 years. So they die 8 years sooner given that BMI. So again, we have that data, but that's just one point in time. It doesn't tell us that we have to get down to a BMI of 25, for example, which is considered normal in order to be healthy, right? So again, we have to reframe that it's just a number to help us understand that you have a risk, and then in a shared decision-making fashion, understand how we're going to address that risk and when and if we're going to address that risk.
Yeah, I think that was really well said. This is one of the bigger challenges in my practice. People coming in, reading in the media or elsewhere about BMI and the importance of getting to a normal or ideal BMI. And often, no matter how much success they have, no matter how much weight they have, if they don't get to the sort of magic number of the perfect BMI, they feel as if they failed and there's no point of even continuing to work on it. So really important that you pointed that out, Dr. Fitch. On that note, I'd love to hear from both of you about what you find to be among the greatest challenges in treating obesity in your practices. Dr. Washington, would you like to start?
Sure. I would say one of the biggest
Uh-oh. I'm not hearing Dr. Washington. I don't know if that's me or everyone else.
I'm not either. Can you hear me, Scott?
I hear you fine.
Okay.
Why don't you go ahead, Dr. Fitch, and hopefully we'll have Dr. Washington back shortly.
Yeah, I was worried it was me and my hotel internet, but I guess it's something else going on in the ether here. I will say one of my biggest challenges is just getting insurance coverage as we are here today. Because this is not seen as a chronic disease, it is relegated to employers to figure out how to treat it. And, if you have Medicare, as we're talking about, you don't have access to treatment. Many of our Medicaid patients, therefore, don't have access to treatment. We're fortunate upwards of 16 states now have added Medicaid coverage. So, separately advocated to have added Medicaid coverage for their constituents in their states. But again, because it's not a standard benefit on our health insurance, and it really should be, because it's the only disease state that's not a standard benefit, and it's our most common disease state. And the reason we, talk about, the issue is that, it costs a lot to treat it, but it also costs a lot not to treat it. And how can we not treat something when now we have such more effective treatment today than we've ever had before? And science has advanced to produce more effective treatment. It's like we now have antibiotics and we never had them before, right? At some point in time, we didn't have antibiotics and people had infectious diseases and they died of them. And then we found antibiotics and we were able to save people's lives. And we're kind of at that similar juncture where we have treatments that now, as Alicia mentioned, have been life-changing for her, life-changing, yet she can't get access to it because it's not seen as a chronic disease that's worthy of treatment. And that's where and yes, the cost needs to come down and we have a lot of issues, but I mean, overall, we just have to get access to treatment, in some way, shape, or form, and then figure out also, solve the problem of cost and how to get access to people.
Absolutely. And we have Dr. Washington back. Sorry we lost you. Why don't you jump back into what you were saying?
Yeah, I'm so sorry about that. I'm not sure how much you heard, so I'll just briefly recap. But essentially, I was just sharing that a lot of the issues that I have when I'm treating people who have trouble with obesity is them getting to the place where they understand that this is not a moral failing. There is no blame. There should be no shame. This is a disease. And as much as you would not feel hopefully ashamed that you have high blood pressure, you shouldn't feel ashamed if you have obesity and it's something you're working on. So there's a lot of social stigma, a lot of bias internally and externally when people are seeking treatment. So that is the first thing. Then when they come and they're willing to talk about their weight, they immediately, as we've mentioned, say like, oh, I'm not willing to get surgery. I don't want medicine. They want to really white knuckle it, kind of rough, make it harder on themselves, unfortunately, because they can't afford the medicine or they maybe don't have safe neighborhoods to walk into. And so I just wanted to say that I try to get them focused on what they can do, but really access to medications, access to safe environments, healthy food that's affordable, salads not costing $15 when a value meal costs $8. Those are things that are really helpful to help refocus the patient. And sorry about my connection.
Thank you very much. It's super helpful. Dr. Fitch, I want to go back to you for one more question. Getting effective treatments covered, I think certainly has to be one of the approaches to addressing obesity. But I know you've been working on a lot of creative approaches to covering obesity treatments and addressing obesity. Can you tell us a little bit more about that and how we can deliver care in a value-based manner?
Yeah, so this is super important. And with other diseases, we've had to do this, right? I mean, a lot of medication, a lot of treatment is costly, especially newer medication and newer advances in science. But again, most importantly is to say, that obesity is a disease and it should be a standard benefit on health policies. And we shouldn't have to have undue administrative burden in order to get even very cheap alternatives. We have medication. I'm the president of the Obesity Medicine Association, which has been around since 1950, 1950. So we've been treating obesity for a long time with medications and other tools, dietary approaches, other sorts of behavioral things, as you mentioned, Scott, that again, a lot of times our patients don't have access to, because when we put that diagnosis obesity up there, it's suddenly excluded. So we need to be able to treat obesity like other chronic diseases, not have these carve outs and these exclusions. It needs to be the standard benefit. And then when we have prior authorizations of medications, make our cheaper alternatives, which are less than $100 a month, even for the branded products. If you look at even the non-branded generic products that we use sometimes as well, those are on the order of $20 to $30 a month. Having those access to those for patients covered by their insurance, is critical. And then, we can figure out how to be good stewards of our more expensive treatment and figure out, who is going to need them because maybe they didn't respond to the less expensive therapies, or maybe they have contraindications, as Dr. Bell Washington mentioned, if they have psychiatric and other issues that they can't take some of these other medications, then they can have access, maybe to these other treatments. So there are ways that we can do this and ways we can work together, just like we did with COVID, right? We had this emergency before us, and I feel like we have an emergency now that we need to say, this is an emergency and we have effective treatment. We can't get it to people because of insurance. We can't get it to people because of supply and other issues, just like we had during COVID. And how can we come together and solve the problem at hand versus just saying, we don't treat it because, we just don't treat it. We're going to stick it over here in this little bucket. So I think we need to come together and really solve the problem at hand to reach that quintuple aim of healthcare, right? Which is trying to do all these things we just talked about.
And I just wanted to jump in there really quickly to say this, that by not providing our patients with obesity treatments of all kinds, but including anti-obesity medication, we're essentially having to wait until they develop a very serious disease that we know leads to so many other complications, amputations and loss of work and, lots of loss of the vitality of life if necessary, if you want to say it that way. But essentially, they don't get a lot of these lifestyle changes. They don't get the medications until they get the diagnosis of diabetes, which we know is higher chance of getting from obesity. So, it's just very important that we do take it seriously and treat it.
And I think perhaps that was a notice that we're out of time. So thank you to our panelists and to everyone for participating today. I hope this was helpful for everyone, and I'm going to pass it back to the rest of the team.
Thank you so much, Dr. Kahan, Dr. Fitch, Dr. Washington, for such a wonderful panel and lending your expertise. I just wanted to highlight, could we go back one slide? I just wanted to highlight some of the key takeaways from this. And number one, as you heard from all of our experts, the importance of treating obesity as a chronic disease, ensuring that patients can have access to obesity interventions is critical. Thank you so much, Alicia, for your story there. And the importance of co-sponsoring and passing the Treat and Reduce Obesity Act, which is a bill that is in both houses of Congress. So in closing, just wanted to say a huge thank you to all of our speakers, all of our co-sponsors, and as well as to our funder, Novo Nordisk, for the support of this briefing. I'll just leave this slide up again so you can see all of them. We will be sharing the recording of this briefing with all the registered attendees, as well as more information. I know many of you indicated in the chat that you'd love to work with AMWA. We would love to work with you. We feel that there's been so much happening in the science of obesity, so much more that we understand. Now we'd really like to mobilize to get some action to how we can improve addressing the obesity epidemic in our patients and helping to create change. So thank you again for being on this briefing today. We will follow up by email.